Hello all, this is Luke Waldron with the American Society of Addiction Medicine. I want to thank you all for joining us. This is our Improving the Language and Coverage of Addiction webinar, part of ASAM's National Addiction Treatment Week. We have three great panelists today. Our first will be Dr. Sarah Wakeman, who's the Medical Director at Massachusetts General Hospital Substance Use Initiative, as well as Michael Botticelli, former White House Director of Office of National Drug Control Policy and current Executive Director of the Grayson Center for Addiction, Boston Medical Center. We also have Jeff McMillan, who's the Eastern U.S. Enterprise Editor for the Associated Press, as well as an AP Stylebook committee member. Our presenters have no disclosures. We will have a quick poll. If you could please take a minute to answer this question. We will have a poll at the end. We will pause for 1 minute to let you answer this poll. Our first panelist is Dr. Sarah Wakeman. Dr. Wakeman will discuss the impact stigma has on patients, describe the shame and stigma associated with addiction and how it deters patients from seeking treatment, as well as describe the language we use related to addiction treatment and how it impacts patients. Thank you.
Great, thanks very much. Thrilled to be here with you guys and to have you listening and to celebrate Addiction Treatment Week. So when we think about language and treatment broadly for addiction, I think it's impossible not to talk about stigma. And in fact, stigma and stereotypes of the illness of addiction and also people who are affected by the illness have impacted our policy decisions and the way we've shaped treatment for really the last century. This is a quote by Dr. Vincent Dole, who is the physician who actually discovered methadone as a treatment for opioid use disorder back in the 1960s. And this is from an interview where he was reflecting on his own sort of educational growth as he came to understand what addiction really is and to care for and care about people with addiction. And really challenging the traditional image that he and many others have had of a person with addiction as being weak in character or pleasure-seeking or unreliable or dangerous. And as he points out, he quickly learned that this was completely false. And yet many of those stereotypes have actually influenced our policy decisions and, again, our treatment structure for the past many decades. Next slide. And yet, despite persistent stigma, we've made huge advances in science. We talk now about this being a public health crisis when we refer to the overdose crisis, and in particular, the crisis of opioid use disorder across America. This was a wonderful piece in the New England Journal of Medicine by our heads of NIDA and NIH, our federal agencies, reflecting on the importance of science, that when we think about public health crises in the past and prior epidemics, it's really been science that's allowed us to get our arms around a crisis and to make sure that we have effective treatment. And yet one of the great ironies in addiction is that we actually have decades of science showing us what's effective and helping us better understand prevention and treatment and recovery. And yet much of what continues to be practiced in the treatment world and much of our ongoing policies and perspectives actually bear little resemblance to what the science shows us. Next slide. What we know from science is that addiction is a chronic but highly treatable condition. Opioid use disorder in particular is a good prognosis disease, meaning most people will get better, which is not something that we talk enough about. We hear a lot about the carnage of untreated opioid use disorder and, of course, the devastation of overdose deaths across this country. And yet the reality is that addiction treatment works and that treatment outcomes for addiction are as good as for other chronic illnesses. We now know from science and from studies that utilize things like functional imaging that addiction is much like other chronic diseases. It's highly genetic, about 40 to 60% based on the genes you're born with. And the other component is based on environment or exposure, much like heart disease or diabetes, where again, about half the equation is genetic and half the equation is based on exposures. We can actually use functional imaging to look at a person with addiction and see, again, similarities with other chronic illnesses. So if we take the example of heart disease, we can look at a healthy heart, and you can see the picture there in the upper left corner of this slide. You can see the bright red throughout the muscle of the heart, showing that the whole heart muscle is functioning normally. We can then look at an affected heart, so a heart where someone's had a large heart attack, and you can literally see that part of the heart is no longer functioning, and that leads to the chronic disease that we recognize as congestive heart failure. Now, we can actually look at functional imaging of a brain and see similar things when we look at the brain of someone who's not affected by addiction and the brain of someone who is. So in a healthy brain without addiction, you can see that the top part of the brain, which is the frontal lobes, and in particular the prefrontal cortex, is a part of the brain that's most metabolically active. And that's the part of the brain that allows us to think about risk and benefit and consequence and to delay gratification. You can think of it sort of simply as the braking system in the brain that puts the brakes on the deeper impulses that we all have to do things that feel good. You can see below it the brain of someone who has active addiction, and you can see that that part of the brain is no longer lighting up. And so if you think of that part of someone's organ has been damaged, and so that person who has active severe addiction can no more willfully choose to get better than the picture of that heart can just choose to pump harder. Again, when someone has active severe chronic illness, it's affected their biology and their ability to function medically. When we look at treatment outcomes, we can also see that addiction treatment outcomes are as good as other chronic diseases like hypertension. But part of the problem is that we built a system that's approached addiction as if it can be fixed with brief episodic bouts of treatment. So we expect that someone can go away for 30 days and come back somehow magically cured from their chronic illness. And yet we would never expect that of a person with diabetes or hypertension or HIV. In fact, if we stop treatment after 30 days, we would look at that as a failure of the medical system. And yet too often with addiction, we've actually been failing patients by sending them to ineffective treatments that are really not based on science, and then unfortunately blaming the patient when they don't get better. Next slide. So I'm an internist and also an addiction medicine specialist. So I provide primary care to patients as well as specialty addiction medicine. And I really see treating addiction, particularly opioid use disorder, is very similar to managing a patient's diabetes or HIV. So like diabetes or HIV, which of course are also chronic illnesses, there's no cure, but the goal is to get someone engaged in treatment and to get them into remission, meaning they no longer have symptoms of active disease. And the reason we care about that is because we want to prevent both acute and chronic complications of untreated illness. So the reason we care about what someone's blood sugar is when they have diabetes is because we don't want them to end up with end-stage kidney disease or to end up with an amputation or a stroke. And similarly with addiction, the reason we care about getting someone into treatment and helping them reduce or stop their use of a substance is because we want to prevent both the short-term consequences like overdose and the social consequences, as well as the chronic consequences like infectious complications such as hepatitis C. With diabetes or HIV, we have similarly decades of research showing us what works when it comes to treatment and what sort of outcomes we want to target. But we then tailor that to the person in front of us. So if I see a patient in my primary care practice who I really think should start insulin because they have very severe diabetes, and they tell me that they're terrified of needles and there's no way they'd ever consider starting insulin, but they'd be willing to consider an oral medication, I would offer them that oral medication and continue to work with them on a pathway towards health and whatever that meant to that individual patient. And yet too often with addiction treatment, things are made to be black or white. Patients are sort of given ultimatums, take it or leave it. And if they're not willing to do everything that's requested as a component of treatment, they're often labeled as being unmotivated or not adherent or not compliant. And then similar to diabetes or HIV, treatment usually includes some combination of medication, behavioral support, ongoing follow-up, so we would never start insulin and then not see a patient again, but rather continue to see that person closely early on, and then helping support the lifestyle changes that are necessary to manage chronic illness. Next slide. So what is effective treatment for substance use disorder or addiction? Well, for most people, it's some combination of medication, and we have highly effective medications for opioid use disorder, alcohol use disorder, and tobacco use disorder. Psychosocial interventions, which are usually either skills-based, really helping people develop skills that we know allow them to cope with stress in high-risk situations and prevent relapse, or focused on motivation, helping people resolve the natural ambivalence that individuals have about engaging in treatment and getting into recovery. And then recovery supports, which are community-based ongoing supports that help really enhance the fabric of someone's life. These are not formal treatment, but can be incredibly valuable as people are navigating what it's like to engage in treatment and manage this chronic illness. Next slide. Medication in particular is crucial when we think about the current overdose crisis. Opioid use disorder is a highly treatable illness, and the most effective treatment we have for it is long-term treatment with medications. This slide is actually from a study that's now a couple decades old, and yet it recently was picked up in the news media and published in The Atlantic a week or two ago. It's a study looking at the country of France, where there aren't specific requirements around prescribing one of the three medications we have to treat opioid use disorder, a medication called buprenorphine. In this country, doctors have to undergo an additional 8 hours of training and get a special license from the DEA, which essentially limits access. So there's fewer than 4% of physicians that have gone through that necessary training to prescribe this medication. In France, all physicians can prescribe the medication, and so they were able to get 90,000 patients treated in less than a decade and saw an 80% reduction in heroin overdose death rates. It's a really dramatic decrease. Studies here nationally in the U.S. have similarly shown that as you increase access to life-saving medication for opioid use disorder, you decrease the likelihood of overdose death by more than 50%. So if there's one thing we could do to immediately stop the death toll, it's really to make sure that people have immediate access to life-saving medication treatment. This would be similar to thinking about getting our arms around type 1 diabetes or HIV, where it was really the advent of life-saving medications with insulin and then with antiretroviral therapy that finally bent the mortality curve and allowed us to really treat these illnesses as chronic diseases rather than fatal conditions. Next slide. And yet, despite huge scientific advances, and I've given you just a tiny little glimpse into what we understand about addiction and treatment, there continue to be massive gaps in care. And this gap between science and practice is one of the greatest challenges we have in addiction medicine. It's really an implementation gap. Of course, we need greater science and discovery, but what we actually need to do is to begin practicing what we know works from science. And the reason for that gap, in large part, is because for a century, we've treated addiction as if it were a social problem or an issue of bad behavior or an issue for the criminal justice system. And that's led to our treatment approaches and our interventions for addiction to really look nothing like the way we think about treating other medical conditions. In fact, I would argue if we treated any other health condition the way we treat many people with addiction, it would be arguably medical malpractice. Next slide. And so why does care look so different? Well, one of the biggest reasons is stigma, and that's what we're going to be focusing on in the rest of today's discussion. So we know that this is not just a U.S. issue. The World Health Organization did an international study where they looked at 18 of the most stigmatized social problems across 14 countries. And out of all of those, drug addiction ranked number one. So people perceived addiction to be more stigmatizing than being a criminal, than having HIV, or than many other socially stigmatizing conditions. We know that people who use drugs, who experience stigma in the healthcare setting, actually have worse mental and physical health because they're less likely to access care, they're less likely to engage in harm reduction services or in treatment. And so that stigma actually literally leads to clinical outcomes. And we also know that it's one of the main reasons why only 1 in 10 people with substance use disorder access treatment in any given year. So despite the fact that we know we have effective treatment, that this is a treatable condition, a minority of people in any given year are going to get any treatment. Next slide. So what is stigma? So stigma is essentially defined as an attribute, behavior, or condition that is socially discrediting. And there are really two main factors that influence how stigmatizing a condition is. And that's cause and controllability, meaning do you think that the person is to blame for their illness or their condition? And do you think that they can control it? And that's really these two factors are among the main reasons why addiction continues to be so stigmatized, because there's a lot of confusion about cause and controllability. Despite all of our conversation and rhetoric about this being a health condition and a public health crisis, many people in their heart of hearts continue to think that people with addiction are willfully choosing to have the condition, that they are to blame, that they've made a bad decision, and they're essentially practicing bad behavior. In addition, many people think that it's under their control. They look at someone who's in the throes of active severe addiction and they think, man, they should just knock it off and pull themselves up by their bootstraps and get better. And so those two factors really influence the amount of stigma we have towards people with drug addiction. Next slide. What impact does stigma have? Well, it has broad and reaching impact across many different sectors. First, it erodes both the public and people who are affected confidence that addiction is a treatable and valid health condition. It can be a barrier to jobs, to housing, to relationships, particularly when we think about the harms of our drug policy and the fact that many people are criminalized for drug use, and that can lead to huge barriers in terms of ongoing employment and housing. It deters the public from wanting to pay for treatment. If you think that someone is to blame for their condition and that they can control it, it's hard to make an argument for parity when it comes to payment and insurance. We know it stops people from seeking help. That's one of the main reasons, again, that only 1 in 10 people seek help. And worse, it actually impacts clinical care and treatment decision-making. So even if a person is able to make it into treatment, when the providers themselves hold stigma about addiction, they actually make more punishing treatment decisions. Next slide. And language is a crucial vehicle through which stigma is conveyed, and that's one of the reasons that we're focusing on it in today's talk. If you think about other health conditions, breast cancer, diabetes, HIV, we use language about the person being afflicted, them suffering, enduring, fighting. We call patients victims or survivors. We really recognize the person at the center of the illness and the terrible toll that an illness can take on that individual human at the core. And yet, when we think about the language we use for substance use disorders, it is very different. We call people abusers, substance abusers, or substance abuse. We refer to them as addicts. We talk about their toxicology testing being dirty. Worse, some places still refer to an individual as a junkie. And then when we refer to someone who's in remission, we talk about them being clean, which of course implies that someone who's actively struggling is dirty. That's language that, again, we would never use for another health condition. So we would never talk about a person with an eating disorder as being a food abuser, or a person with diabetes being a sugar abuser. It would sound sort of ludicrous if we use that for another health condition, and yet it's terminology that's regularly used when it comes to addiction. Next slide. And so why does this matter? Well, abuse in particular is one of the most pernicious terms that is used, and it's used incredibly commonly, as I'm sure you're all aware. If we actually look at where the term abuse comes from, it has its roots in an Old English word that is derived from a word meaning a wicked act or practice, a shameful thing, a violation of decency. So obviously implying that someone is willfully doing something terrible. If you think about other terms that are commonly used that have the term abuse in them, they really refer to awful, violent, and very willful acts such as rape, domestic violence, and child molestation. So sexual abuse, domestic abuse, child abuse. And again, it's really not a term that we would use for any other health condition. Next slide. This may sound just like an issue of semantics or political correctness, but actually this has been rigorously tested. One of my colleagues actually did a study looking at highly trained mental health clinicians, so PhDs or master level therapists, and gave them a vignette, so a description of a patient, where the only thing that changed was whether the patient was described as a substance abuser or a person with a substance use disorder. In the case where the patient was described as a substance abuser, these highly trained clinicians actually recommended a more punishing course of treatment. So words matter. They influence the way we think about people. They influence our judgment and our decision making. And for clinical care, they actually influence the way clinicians think about treatment. We know amongst the public from national surveys that if you describe a person as a drug addict versus as a person with an opioid use disorder, the member of the public is more likely to have higher rates of stigma towards addiction. So again, that language influences people's perceptions and their stigma about the condition. And then people in the public who hold more stigmatizing views of addiction are more likely to support punitive rather than public health policies. So language and stigma translates, one, into clinical care, but then also into how the public thinks about supporting policies at the state and national level, which is obviously of crucial importance right now. Next slide. There's also a number of terms that are used that are just frankly medically incorrect. So we frequently see headlines about addicted babies, tiny little opioid addicts, or born addicted, or some common phrases. And yet by definition, a baby cannot have addiction. If we think about the definition of addiction, it's defined as compulsively using a drug despite harmful consequences. So babies who are born with neonatal opioid withdrawal syndrome, meaning that they're experiencing withdrawal symptoms at birth, do not have addiction. They're not compulsively using a substance despite harm. And that terminology really enhances stigma towards pregnant and parenting women who themselves are struggling with substance use disorder. It also worsens stigma about some of the most effective treatments we have for opioid use disorder, like that medication buprenorphine I mentioned, or methadone, which is actually the gold standard in opioid use disorder treatment and has been around for many, many decades. Because women who are effectively treated with those medications and in remission, in full remission during pregnancy, their babies will experience opioid withdrawal syndrome at birth. That does not mean that the baby is addicted or that mom is still addicted. It's simply a predictable and very treatable outcome of the management of that mother's chronic illness. We also frequently see confusion about the difference between dependence and addiction. So that example about babies is one example of that, but another is around treatments for opioid use disorder. So frequently we hear confusion about people being, quote unquote, addicted to methadone or addicted to buprenorphine. And that, again, really misunderstands the definition of addiction. That, again, addiction is compulsively using a drug despite bad things happening to you. Taking a medication daily that a doctor prescribes to you that allows you to function and parent and work and allows you to not have an overdose and not continue to use opioids and not get hepatitis C does not meet criteria for addiction. If that met criteria for addiction, then every person in America would be addicted to their cholesterol medication or their diabetes medication. A person who's taking a daily medication to stay healthy is someone who's successfully managing their chronic illness, and yet frequently that's not how we portray that sort of treatment in publication. And then again, very disparaging language in general about these treatments, despite the fact that they're the most effective. And that really contributes to the continued stigma about medication treatment for addiction. And so locally in Boston, for a long time, we saw a lot of reference to an area of town in Boston referred to as methadone mile, and really disparaging reference to people who are actively struggling with addiction who are very visible in public, and the fact that there was a nearby opioid treatment program that offered methadone. And yet the assumption was that the people who appeared so unwell in public were in fact being treated with methadone, which really worsens that public understanding of methadone as a very effective treatment for opioid use disorder. Next slide. Thanks. So how can we change our language? Well, if you think about some particular recommendations, so words to avoid would be dirty. So again, not referring to people's toxicology or to people themselves as being dirty. And because of that, to also not use the word clean, again, because the assumption then is that someone who's actively struggling is dirty. To not use the word addict, abuse, or abuser. And then to consider changing even the terminology medication-assisted treatment, which is a very commonly used terminology to refer to medication treatment for opioid use disorder. So why should we change that? That doesn't sound very offensive, and none of the language in that is offensive. But part of the problem is that there continues to be this misunderstanding and stigma about the role of medications in the treatment of addiction. And the term medication-assisted treatment seems to imply that medications are some corollary to some other treatment that's happening. And yet we know that medications are life-saving, just like insulin is for diabetes. And yet we don't refer to diabetes treatment as insulin-assisted treatment, even though, of course, there are many other behavioral interventions that are crucial with diabetes care, and not everyone with diabetes needs insulin. So really thinking about using language that's similar for addiction as language for any other health condition. Next slide. And so that stigma about medications for addiction treatment is just so crucial because it continues to be one of the greatest barriers we're facing right now in the midst of this overdose crisis. In 2016, our former Surgeon General, Vivek Murthy, put out this amazing report, the first ever Surgeon General's report on alcohol, drugs, and health. And he highlights the fact that the science is very clear that medication treatments for opioid use disorder are the most effective treatment we have. They work, and yet they continue to have their critics and continue to have people who misunderstand the use of these medications as just substituting one drug for another. And that perpetuates many programs that continue to focus on not allowing medications and, in fact, frank violations of the American with Disabilities Act, of people who are successfully treated on medication treatment who are either not able to access it or not able to access other important parts of care. And so our language around this really matters. Next slide. So what can journalists do? We'll make a couple things. So first, using appropriate and precise language when covering drugs and addiction. There's a lot of terminology out there, but if we want this to be seen as a medical condition and an issue that needs to be addressed with science, we really need to use precise terminology when we refer to it, much as we would with any other science reporting or health reporting. And when we think about other illnesses, we use respectful person-first language, and we've gotten rid of outdated and stigmatizing terminology. So you think in the past we used to refer to people as lunatics or maniacs. We would never say that now. We would talk about a person with bipolar disorder. Similarly, we don't talk about the breast cancer or the lung cancer. We talk about a person with breast cancer, really highlighting the fact that people are people first and that they may have an illness and yet it doesn't define them. And so if you think about a term like addict, it really distills someone down to being the only thing about them that we are talking about is the fact that they have the disease of addiction. There are certain terms of specific diagnostic meaning, like addiction and dependence, that should not be conflated. And in fact, conflation of those two things can really worsen huge misunderstandings about both the illness and about treatment. And then importantly, when reporting and when doing background, it's really important to talk with medical experts, much like you would with any other health condition. Often with addiction, there are many opinions out there and many people with strong opinions who are happy to offer that. And too often in articles, we see, criminal justice officials or people in the public given sort of the same weight as someone who's a physician who's specially trained in that area. And it's not that those other perspectives don't matter, but if we think about reporting again on, cancer and diabetes, a journalist would really turn to the medical experts as being the ones who hold sort of the scientific truth on the issue and then get other people's perspectives about the experience. And so really thinking when reporting about addiction, about approaching it the same way you would any other health condition. So with that, I'm going to turn it over to my good friend and colleague, Michael Botticelli.
Great. Thank you, Sarah, for that excellent overview, and thank my colleagues at ASAM for putting this webinar together. What I'd like to do today is just talk a little bit more in terms of our historic attitudes of addiction, a little bit deeper dive into how public attitudes drive public policy, and listen, describe what we know about certain frames affect stigma and policy. Next slide, please. So as Sarah talked about, our understanding of addiction has really been framed as addiction as a moral issue about bad people doing bad things. And if you look at the trajectory of federal drug spending going back to the 1980s, the preponderance of federal drug resources against substance use disorders has been largely on the supply reduction and law enforcement and not as much around a public health issue. Secondarily, we've seen people who are addicted as a choice. And while there are certainly behavioral issues that play into when people first use, it's a dramatic misunderstanding of the chronic nature of this disorder. That's highlighted by a recent survey done here in Massachusetts by Blue Cross and Blue Shield. And while the vast majority of respondents saw this as a matter for public health as opposed to law enforcement, fully 82% of respondents saw people with a substance use disorder as either mostly or partially to blame for their addiction and continuing to use as a barrier for people's ongoing recovery. This is an issue that's largely been ignored by the scientific and medical communities, and I know that our response to this epidemic is how do we get more people trained, how do we integrate issues of medical education into primary care and into medical schools. I also think it's important to understand that it's shaped by an individual's personal experience, that while many people know people who are addicted, that certainly plays into people's own attitudes about how we approach people with addiction. We also know that media portrayals and, as Sarah talked about, language play a very important role in terms of people's individual attitudes around addiction. I also think it's important to note that many people in recovery were anonymous, and so people actually did not have a good understanding or a personal knowledge about the fact that people can and do get better and go on to live incredibly vibrant lives. Next slide, please. So this is a really good illustration, as Sarah talked about the way that people's own individual attitudes drive public policy. This is a 2014 article of a survey done by the Johns Hopkins Bloomberg School of Public Health, and show that even when compared to people with mental illness, there was a tremendous amount of opposition to giving people good health benefits, that employers should deny employment to people with a substance use disorder, that landlords should deny housing, or even believe that recovery is possible for both disorders. As Dr. Wakeman talked about, both employment and housing are two vital supports for people to maintain ongoing recovery. Next slide, please. So this is just a snapshot, and I think Sarah talked about this. I think many of us who have been doing this work have been disturbed by the media coverage of this epidemic, largely focusing on the use and some of the destruction associated with it, without having a comparably balanced approach in terms of focusing on the fact that people can get better, they do get better, and that many people are in recovery from an opioid use disorder. I think we have to really focus on working with the media to make sure that we have adequate portrayals, not just around the destruction, but also making sure that we have good positive coverage of the millions of people who are in recovery. I also think it's important to note that these kinds of imagery, particularly of people using in paraphernalia, can be significant triggers for people, particularly in early recovery. And we know if you look at brain imagery of people who see some of these images, we know that it actually increases and increases cravings and destabilizes people in early recovery. So I think, we have to make sure that we are not continuing to perpetuate the misunderstanding that treatment works, but also not inadvertently triggering people who are in early recovery. Next slide, please. So what do we know about certain frames affect stigma and policy and attitudes? And again, this is done by health communications experts at Johns Hopkins Bloomberg School of Public Health. And, one of the things that we know is portraying treated addiction. So portrayals of successful treatment and recovery can really reduce stigma and support for punitive policies. So making sure that we have good, accurate portrayals of people who have successfully gone through treatment and who are stabilized and have gone on to live productive lives really are important frames for how we report on addiction. And similarly, portraying barriers to treatment access, so explicit descriptions of the barriers that people face can increase support for expanding treatment. Even with all of the work that has happened over the past few years, we know that people still do have significant barriers in terms of their ability to access treatment. So we know that more sympathetic and realistic portrayals, not only of the barriers people face, but of positive portrayals of people in recovery can really diminish stigma and contribute to evidence-based public policies. Great. So with that, I will turn it over to Jeff McMillan.
Thank you to my co-panelists. You've both given me a great basis for how journalists can put some of this stuff into practice. First, next slide. I'd like to talk about what the AP Stylebook is. I think most journalists on this call are probably familiar with it, but it's known as the definitive resource for journalists. It's been updated regularly since its eventual publication in 1953 and is known as the must-have reference for writers, editors, students, and professionals. It provides fundamental guidelines for spelling, language, punctuation, usage, and journalistic style. In 2016, the AP produced on its national wire alone 521 stories that contain the word addiction and 549 stories containing the word heroin, with many others referencing the words addict or opioid. Before 2017, the AP Stylebook had no guidance on addiction language and only limited guidance on language around drugs and drug use. So given the volume of stories about addiction in recent years, some guidance was deemed necessary, and I was assigned to research the matter and present language recommendations to the AP Stylebook Committee, which is made up of several editors from around the organization. In determining style guidelines, the AP is driven by the tenets of accuracy and fairness. This practice holds true for the AP's journalism and, in general, for all reputable organizations that cover the news. Some of the guidelines the AP created around addiction may have the side effect of removing stigma, which is a large part of what we're talking about today. I would just want to note that while a lot of people see that as a plus, especially people in the medical community, plenty of others may not, and those are people we also cover in the news. Those include many people and politicians who see drug addiction as a criminal matter and favor punitive measures for people who use drugs. As a news organization, the AP does not take a position on this question of stigma or criminality. Rather, our guidelines are based on what science says around addiction. It's about fairness, it's about accuracy, and it's also based on what we think our customers and readers will understand. So there was a balance we had to strike between accuracy and readability. Just to give you a quick rundown on the AP's guidance, addiction to what the AP Stylebook says is addiction to alcohol and other drugs is considered a disease that affects a person's brain and behavior. It can cause changes in brain circuits and chemistry that lead to inability to control use despite resulting harmful behavior, including damage to health and relationships. Genetics, mental illness, and other risk factors make certain people susceptible to addiction. Not all language and recommendation used by the scientific and medical communities were incorporated into the AP's guidance. For instance, alcoholism is still acceptable according to the AP Stylebook for an addiction to alcohol, despite its increasing identification by scientists as an alcohol use disorder. Note that we do, though, allow for more scientific terminology, such as substance use disorder, but we generally don't recommend that writers choose the term for their own description. This is in keeping with the AP's general guidance to avoid jargon. Some other guidance from the AP is to avoid words like abuse or problem in favor of the word use, with an appropriate modifier such as risky, unhealthy, excessive, or heavy. Misuse is also acceptable. Don't assume all people who engage in risky use of drugs or alcohol have an addiction. We do advise people to avoid words like alcoholic, addict, user, and abuser unless they are in quotations or names of organizations, such as Alcoholics Anonymous. Many researchers and organizations, including the couple we just heard from, and the Office of National Drug Control Policy, the International Society of Addiction Journal Editors, all agree that stigmatizing or punitive sounding language can be inaccurate by emphasizing the person, not the disease, can be a barrier to seeking treatment, and can even prejudice clinicians. Instead, we recommend people choose phrasing like he was addicted, people with heroin addiction, or he used drugs. I would also point out, as another co-panelist noted earlier, abuse can carry connotations of crime and violence. Think about domestic abuse. While words like risky, substance use, misuse, etc. often refer to a disease. Keep in mind there's not a magic line where use becomes so-called abuse. Rather, it's more accurate to refer to use with a modifier that appropriately describes the nature of the use. Some people may argue that there's an argument to be made, and this is not necessarily an invalid one, that this isn't how people talk, so it isn't how we should write. I would note that's not totally true. More people are beginning to talk and write this way, as you've already heard from our other presenters today. Even so, why, as a journalist, would you take more words to say something like a person with addiction instead of, quote unquote, an addict, when being concise is a central value of journalistic writing? I note this is also true for broadcast writing. The new language may take more time to read and write, and it may even sound funny to us now, but think back to 30 years ago when phrases like AIDS victim were the norm. Person with AIDS or people with AIDS sounded funny back then, but it wasn't accurate. First, it implied that all people with AIDS had surrendered to the disease. Second, what does victim mean? It can mean someone who's ill or someone who has died. It's just a vague, inaccurate term. So getting used to the new language around addiction may take time, just like person with AIDS did. I would note that we are also seeing declining use of disease-first language for other diseases besides addiction. For instance, we see fewer references to words like hemophiliac, autistic, diabetic, and especially schizophrenic. Next slide. Other organizations have not necessarily followed the AP suit. Some news outlets have no style on addiction or continue to use language like addict, user, and abuse. For journalists, those may be valid choices. Such words remain very common and are not necessarily seen or perceived, at least consciously, as derogatory. As far as journalism goes, it's not a settled matter. But there is kind of a chicken or egg dilemma. Publications and broadcasters try to reflect common usage, but do journalists also promulgate inaccurate language by not changing our styles and guidance? Next slide. Our jobs as journalists require us to constantly challenge ourselves for new ways to describe what we're writing about. Language around addiction should be no different. There won't always be an easy word to substitute for addict or abuse and the like. In such cases, you might try reworking the sentence. That goes for headlines, too. Anyone working with a one-column headline space that would be able to tidily fit in the word addict but not person with addiction is probably not too happy with AP's guidelines. I would just refer you to a real-life example from the AP archives. We had a headline for a story about insurance fraud at addiction treatment centers that initially read, "Some treatment centers keep addicts hooked for insurance money." We needed to rewrite it to remove the word addicts to keep with our own style, but frankly, when I looked at the original headline, it just was not very engaging. So we changed it to hooked, hoodwinked. Some drug rehabs aim for relapse and money, which in our biz is a much more clickable headline. So I would just like to note that even though these guidelines may seem difficult and sometimes counterintuitive to what we do as journalists, by challenging yourself to find new and creative ways to describe addiction, you will be improving your end product in addition to exercising your own journalistic muscles. Thank you.
Great. Thank you so much. I want to thank all of our presenters for giving those wonderful and in-depth presentations. We will now have a quick question and answer portion. If you have any questions, please use the GoToWebinar question box and submit them. Please note to all panelists, we'll have your microphones all live for any cross discussion. Our first question will be for Dr. Wakeman. How is the medical community trying to change the stigma among providers, and has there been any movement to change language that clinicians use?
Yeah, great question. I think, first just to note that providers are people too that are as deeply influenced by societal stigma as everyone else, and in particular because most physicians and healthcare providers have received little to no training or education about addiction, and so many have no greater knowledge of it than some lay people. And so I think there's a huge need for greater education and awareness, and there's been lots of focus on that from ASAM, obviously, but also from the American Medical Association, from other medicine societies like the Society of General Internal Medicine, and then at local institutions. So I think greater awareness and education is huge, and I think changing language and having peer role models show the importance of language and really educating people about it. I think most people don't intend to use language that's stigmatizing. They just truly don't know that it's either outdated or inaccurate. And so really providing some awareness about that is important. And then lastly, I think focusing on how do we make treatment more available. And I think mobilizing our healthcare workforce is crucial because there's only a few thousand addiction specialists across the country. And so if we think about the current crisis where 64,000 people died last year from a drug overdose and millions are affected by substance use disorder, if we're truly going to get our arms around this crisis, we need to engage and train up our non-specialist physician and nurse practitioner and physician assistant colleagues as well. And so continued efforts on that across the country, which are ongoing, I think is crucial.
Sarah, this is Michael Botticelli. I just want to add to that piece of, while Boston Medical Center has a wide variety of addiction treatment programs, and while we want to make sure all of our clients are treated with dignity and respect, as part of our Recovery Month activities last September, our CEO actually sent out a Words Matter pledge to all staff in the hospital, asking them to sign a pledge using only clinically appropriate, non-stigmatizing language for the use of people, for use in our clinical care settings. And I think that is a really appropriate thing for any institution, but particularly a healthcare institution, to make sure that not only are we giving them all the training that Sarah, Dr. Wakeman talked about, but also I think doing a direct plea to our clinical staff and making sure that they are only using clinically appropriate language.
Great, thank you so much. Our next question will be for Jeff. If the media wrote about addiction without derogatory language, do you think this would cause more people to seek treatment?
Not being an expert necessarily in addiction, or frankly even addiction terminology, even though I did help write this section, I can't really say that, but that is what research has pointed to, and I think Michael Botticelli can probably speak to this better because, frankly, one of the papers I looked at when we were formulating this guidance was a document he wrote during his time as director of the White House Office of National Drug Control Policy, that clinicians themselves can be prejudiced even by this language. So I would not be surprised if eventually, if the language changed over time, that people with addiction themselves might be encouraged to seek treatment. But honestly, that's not my area of expertise.
Sure. So this is Michael, and Dr. Wakeman talked about this during her presentation. When you look at one of the main reasons why people who, even though they know that they have a problem, don't seek care, one of the biggest reasons that they cite are stigma-related reasons, the fear of what their neighbors and their friends and their employer are going to think. So we have to work both simultaneously on including or expanding access to treatment, but there is kind of direct evidence to suggest that if we diminish the stigma associated with it, that more people will be able to seek care and actually seek evidence-based care because some of the language that we use, particularly around these highly effective medications, I think prompt people to seek the wrong care for those that do it. So lots of evidence to show that, yes, if we decrease stigma, we can actually increase people's ability to seek care. The second thing that I will say, too, and I think both Sarah and I tried to talk about this, is that stigma has a direct role in larger public policy, whether or not we offer a treatment benefit, whether or not politicians believe that this is something worthwhile or that these people are worthwhile to invest in. So I think it has the potential not just to expand access and to accelerate access on a personal basis, but also ensure that we are focusing on this as a health condition and not just as a criminal justice issue.
Great. Next question will be for Michael Botticelli. Michael, what people who describe themselves as addicts or clean or sober, changing their language, does that mean that you're trying to strip away something that they define as themselves?
So I think it's important to note, and I say this as a person in recovery, that I think, as people in recovery, we also have to change our language as well. And I think that we know, stigma, there is a self-stigma that people carry, and that includes people impacted by addiction and people in recovery. So I think, one, we have a responsibility to kind of change our language as well. But I also think it's important to note that often if you are kind of a member of a community or group, that we often use language when referring to ourselves or other people that don't necessarily get perpetuated in kind of media and in public ways. So, I do think that people in recovery, that kind of language change is also something that those of us in the recovery community, I think, have an obligation to make sure that when we're talking about this in public settings, that we not use language that we might use in talking to each other. But I also think it's important to know that we often have people who are in certain communities who are often use language and words that don't get perpetuated in the media or in a public setting.
Great, and this is a kind of a more open question. But during the presentation, it was mentioned that the reporters should talk to or speak to someone not as being an addict, but someone addicted or dependent on opioids. What is the difference between addicted and dependent, and how should we know the difference?
I can take that. I commented on that a bit in my comments. I think it's actually a really important distinction. So dependent refers to physiologic dependence, which basically means that if you don't take a daily medication or a substance, you'll get sick. So someone with opioid addiction is dependent on opioids, meaning if they stop taking heroin or a prescription opioid, all of a sudden they'll experience withdrawal symptoms. But someone who takes many different kinds of medications can also have physiologic dependence. So someone who's taking prescribed opioids for chronic pain, or someone who is taking an anti-anxiety medication to manage generalized anxiety disorder, or even someone who's taking insulin to manage insulin-dependent diabetes. All of those people are dependent on their medications, meaning that they will get physically sick if they stop taking them, but they're not addicted. The addiction is defined by compulsively using a substance despite bad things happening to you. So it's really defined by the loss of control and the consequences that come from the use of the substance. So one of the criteria for addiction is physiologic dependence, but it's neither sufficient nor necessary to make the diagnosis. The reason why that distinction matters is because I think it can improperly malign patients with chronic pain who are appropriately taking opioids for chronic pain, who will all be dependent on opioids, but the vast majority of them do not have addiction. And also because it perpetuates some of the stigma and misunderstanding about the use of medication treatments for opioid use disorder, because both methadone and buprenorphine induce dependence. That's part of how they work, but the person taking them is not addicted to them. And so that's it's a very important distinction, even though often the terms are used interchangeably.
This is Jeff. I would also note that distinction was important enough that we did determine it needed inclusion in the AP Stylebook and our guidance. We can't go into depth as a medical encyclopedia because we're a reference guide, but we say do not use the terms addiction and dependence interchangeably. Addiction usually refers to a disease or disorder. Dependence may not involve one, such as some babies born to mothers who use drugs or cancer patients who take prescribed painkillers.
Great. We're just on our last final two questions. The second to last question is for Dr. Wakeman. Dr. Wakeman, what is the difference between addiction and substance use disorder?
Great. So that's a complicated question. So substance use disorder is the terminology used by the DSM-5. So DSM is the Diagnostic Statistical Manual. It's sort of the psychiatric Bible, if you will, that includes all of the diagnoses within the field of psychiatry. And so it is the basis on which we make a diagnosis. And so there's 11 criteria that a person can meet. You have to have 2 or more of those criteria to meet criteria for having an opioid use disorder. And the diagnosis is substance specific. So you could have a severe opioid use disorder and a moderate cocaine use disorder, but we identify each of those specifically. Addiction is a term that is defined to mean really a primary chronic disease of brain reward and motivation circuitry. So it's that defined as that compulsive use of a drug despite harm. So generally, when we're using it colloquially, addiction is synonymous with moderate to severe substance use disorder. So people who have milder forms of substance use disorder, many of them can get well without formal treatment. But when we think about the moderate to severe end of the spectrum, that's usually what overlaps with the diagnosis of addiction and generally requires formal medical treatment.
Great. And this will be our last question. This is for Michael Botticelli, but all panelists, please feel free to chime in. But this is, what way can the media play a positive role in the addiction epidemic?
So I think there are a couple ways that we could do that. One that we talked about is making sure that we try to use make sure that we're representing this issue in a much more comprehensive way than just some of the media portrayals that we have seen that would lead one to believe that treatment is not effective and that people don't get better. I think I think the preponderance of coverage, while it's really been helpful in kind of showing the magnitude of the problem, often focuses on the incredible mortality and morbidity that we've seen with this. And I think one of the things that would be helpful is balancing that approach with the millions of people who have actually gotten care and help, and also making sure that we are not misrepresenting highly effective treatments. I think during Sarah's presentation, she had one headline that I think was particularly exemplary or a particular example of how we can misrepresent highly effective treatments and really equate them with ongoing drug use. And that was the reference to methadone mile. So I think it's really important that reporting be scientifically sound, making sure that we are portraying both the imagery and the stories of this in much more holistic ways. And again, representing the fact that people can and do get better if they're giving good evidence-based care.
Great. Well, I want to thank all our presenters as well as all those who participated in today's webinar. This webinar is being recorded and will be live on our website. You can visit treataddictionsavelives.org to learn more about National Addiction Treatment Week, as well as view this recording and more. At this time, we will end the webinar. Again, I want to thank all of our panelists for joining us today. Thank you.